Welcome to Counselor Soapbox video channel, learning about alcohol part 34, Psychiatric Considerations and Co-occurring Disorders. There's a huge overlap between clients with substance use disorders and those with mental illnesses. Co-occurring disorders are an expectation, not an exception. Substance use disorders are a mental health issue or diagnosis in the DSM-5. While substance abuse counselors are not specifically trained to treat mental illness, substance abuse counselors need to know the basics of mental illness. That includes such things as suicide assessment, recognizing when a client may be considering taking their own life, the mental status exam to see how they are functioning mentally. Substance abuse counselors are often trained on the ASI, Addiction Severity Index, which includes questions that screen for mental illness, and some knowledge of medications and their abuse potentials are also important for mental health and substance use disorder counselors. There are three ways in which substance use disorders and mental illness may be connected. Substance use can often look like a mental illness. When certain drugs first arrived on the scene, people in hospitals were diagnosing a lot of drug users as having schizophrenia because they were hallucinating, but in fact the hallucinations were caused by the drugs. Substance use can cause mental illnesses. Prolonged use of alcohol can result in severe depression and so on. But lastly, clients become attached to their drug of choice. It becomes their primary relationship, and giving up the drugs and the alcohol can create feelings of grief, loss, and anxiety and depression. While treating suicidal clients is not specifically the job of drug and alcohol counselors, at some point in their career, most drug and alcohol counselors will encounter a client who is suicidal. Some basic things you should know and should handle. Whenever possible, get a second person in the room. You don't want to have to leave the client alone when they're feeling suicidal, and having that second person in the room can allow one person to step out and make needed phone calls. Don't ask with dread, "Are you going to kill yourself?" There's no evidence that asking someone if they're thinking about suicide will put the idea in the head of someone who is not. If you ask the question as if you're afraid of the answer, the client may try to protect you by not telling you the truth. They also may not tell you the truth because they want to get out of the room and go home where they plan to kill themselves. Asking about suicidal thoughts and intentions may result in your saving the life of a client. Some basic information about handling the situation in which a client says they're thinking about suicide. Whenever possible, get an advanced professional to sit in. More and more drug and alcohol treatment facilities have master's level or licensed therapists working there. Call 911 or the emergency number in your area as needed. Police departments, at least in California, are not supposed to transport mentally ill people in police cars, but they call an ambulance, and that person can be sent to a mental hospital where they can receive care. Create a safety plan, not a promise to kill themselves. Making someone promise they won't do it leads to people lying to you and then going home, and about 30% actually go through with it. Creating a safety plan, who will stay with them, who they will call, what they will do with the weapon if it's in the house, those sorts of things increase the probability that the person will not successfully complete a suicide. And give your clients contact information, even if their idea of killing themselves is not imminent. Having the suicide hotline or other emergency numbers can help keep them safe. Suicide risk factors for when the thoughts of killing yourself may actually turn to actions are age. Teenagers are more likely to be impulsive, and the elderly, and as people age, the older they get, the larger the risk that they might actually act on their thoughts of suicide. Women attempt far more often than men, mostly with pills and overdoses of medication. They don't die as often because the stomach will contract the pyloric valve and throw up the pills, and often they didn't take quite enough to be fatal, but those overdoses of pills or medications can kill at times and can cause long-term health damage. Men are more likely to complete suicide attempts because they use more lethal means, guns, cars, walking in front of trains, those sort of things. Ironically, white, Caucasian people are at higher risk, and a history of attempts in the past greatly increases the risk. If you have people with any of these risk factors, which covers an awful wide section, you should call for professional assistance. Some other suicide risk factors which should make you consider the possibility even if the client hasn't brought it up. If your client has had family or friends who completed recently, that increases the risk. If they have a definite plan how they would go about doing it or a specific date, those increase the risk. Clients who live alone or have had a recent loss of partner, divorce, or death, that increases the risk. Typically, city dwellers, unemployed, people without a religious belief, people with chronic illness, high levels of anger, and depression, all of those are high risk factors. Lastly, substance use, current active substance use, greatly increases the risk. Binge drinkers, those who drink to intoxication, are 55 times more likely to attempt suicide than non-binge drinkers. IV drug users, 14 times more likely to attempt suicide, and other drug use increases the risk by a factor of about 10 times. It's important to know the difference between suicidal behavior and non-suicidal self-injury, sometimes called cutting, though the client or person who is doing non-suicidal self-injury may also burn themselves, bang their heads on walls, or do other self-injurious behavior. Generally, people who do non-suicidal self-injury do it as a way of regulating their emotions. When upset, they do it. And it's not a suicide attempt. So everyone who cuts on themselves or burns themselves doesn't automatically need to be sent to the hospital as suicidal. But you do need to do a full assessment on any non-suicidal self-injuring person, cutter, because it is possible for people to both do non-suicidal self-injury and then develop thoughts of killing themselves. Drug and alcohol counselors should know enough about mental illnesses to know when to refer their client for mental health treatment. Some major illnesses to watch out for are depression, and people who become severely depressed lose the ability to even take action on their other plans for recovery. Anxiety can interfere with them getting clean and sober and can become so debilitating that they're not able to live their lives. Counselors should also watch for a history of trauma in the past and stress-related disorders in the present. And adjustments to life changes are also a major cause of mental health crises. Other mental health issues that drug and alcohol counselors need to watch for are psychotic disorders. Being under the influence of many drugs can look like psychosis, hearing and seeing things and having other perceptual distortion. But as the drugs leave the system within 72 hours, those symptoms should all disappear. If a client has been without drugs or alcohol for a longer period of time, say 3 days, and they are still hearing, seeing, feeling things, then they need to be referred to a hospital or to a psychiatric facility for treatment. Dementia or something caused by a medical condition is not something that's going to respond to talk therapy or treatment for addiction. Also, counselors need to look for autism or learning disorders. Clients with these conditions need special treatment, may not be able to benefit from the standard drug and alcohol treatment. Also, eating disorders, their behaviors of those with eating disorders may be very similar to people with an addiction problem, but those can be life-threatening, and clients with eating disorders need to be referred to specialized treatment. In talking about psychiatric conditions, co-occurring disorders, and the use of psychiatric medication, we need to be aware of a long-standing controversy. Many people question whether someone in a recovery from a substance use disorder can or should take psychiatric meds. Some programs will not allow clients to take any psychiatric meds and therefore are not good choices for anyone with a serious mental illness. Some self-help programs may tell clients they're not clean if they take their meds. It's important to notice that AA's position on psychiatric meds, remember one of the two co-founders of Alcoholics Anonymous was a medical doctor. AA's literature tells us that if people are able to take psychiatric meds as prescribed by the doctor, then it is a good thing to do. They should follow their doctor's advice. If they find themselves increasing the doses or taking them other than as prescribed, then this is not a good sign for their recovery. It's helpful if counselors know a little bit about psychiatric medications. Counselors need to be very careful not to recommend or to tell clients what they should be taking or not taking. You need to stay within your scope of practice, but some knowledge of how the medications work can help you know when to suggest the client needs to talk to a psychiatrist or other medical health professional. Some basic psychiatric medications are antidepressants. Antidepressants do not suddenly make people happy. They build up slowly as the client adjusts to them, and eventually they begin to help reduce the symptoms of depression. Anti-mania or mood stabilizers have a low risk of abuse. Many clients don't like taking them, but they can really help keep people out of trouble who have bipolar disorders or similar conditions. Antipsychotics can help with thinking, feeling, seeing things that are not real. Anti-anxiety drugs are basically tranquilizers. Unfortunately, these can be used briefly for an episode of anxiety, but repeated use results in a high abuse potential. So any substance abuse counselor who has a client who's taking any anti-anxiety meds needs to work closely with the physician. Sleep medications can also have high abuse potential and are risky for people in recovery from substance use disorders. Just because you can buy something over the counter or a home remedy or alternative therapies does not make them safe. And so drug and alcohol counselors need to know about this and to encourage their clients to talk to their medical professional about any of these over-the-counter, home remedy, alternative therapies that they use. There are also a few medications that are used in combination with another psychiatric med in order to manage symptoms. Cogentin is one, and there are many, many others. The drug and alcohol counselor should be aware of these medications, and if they are causing unexpected symptoms, refer the client back to the prescribing physician. What's ahead on the Counselor Soapbox video channel? More videos on drug counseling, drug education, mental health, and wellness. If you've enjoyed this video, please click the like button below. Comments are always appreciated. And if you want to see new videos in this series, please subscribe. Thanks for watching. For more information, please visit my blog, counselorsoapbox.com. David Joel Miller fiction and nonfiction books are available on Amazon.